Hey everybody. I think it's time to get started. So welcome back. Hope you all enjoyed the break. Visited with our generous vendors, had some time to socialize with colleagues. I'm Andrew Zigman, Division Chief at Northwest Permanente and Clinical Professor of Surgery at Dornbecker Children's. This here's my buddy Tim Jenselowitz, Professor of Surgery and Pediatrics at Luke Boner Children's Hospital, University of Tennessee Health Sciences Center. Just some quick reminders, which are, if you come up to ask a question, please state your name and the institution that you're from. Also, program committee members, please remember to score the sessions. And my sympathy to the Habs fans. It's been rough, I get it. This starts our second set of scientific sessions, focuses on thoracic surgery, and my honor to introduce our first presenter. We have Dr. Kennedy. Come on up, please. Tell us all about biopsies.
Oh, okay. Thank you. All right. Thank you for coming. My name is Kara Kennedy. I'm doing my research at the Children's Hospital of Philadelphia. My talk today is entitled The Diagnostic Yield of Open versus Thoracoscopic Lung Biopsy to Diagnose Non-Malignant Pulmonary Disease. I have no disclosures. When there is a diagnostic dilemma in a child with non-malignant pulmonary disease, our medical colleagues may request a lung biopsy. Frequent clinical scenarios include the question of possible fungal infection in a lymphoma patient on chemotherapy, interstitial lung disease in a patient with persistent O2 requirement, or pulmonary capillaritis in a patient with hemoptysis. Lung tissue may be sampled by IR, advanced bronchoscopy, or surgically. Surgical lung biopsies may be performed in an open or thoracoscopic fashion, and as there is morbidity associated with undergoing any surgical lung biopsy, we were interested in investigating the association between operative technique and diagnostic yield, as well as how patient characteristics play into this. The literature on this is lacking, and this is why we performed this research. We believe it is important as it can assist surgeons in the preoperative decision-making algorithms when choosing a surgical approach. So the purpose of our study was to compare the diagnostic yield of open versus thoracoscopic lung biopsies in non-malignant pulmonary disease. To do this, we retrospectively reviewed the electronic medical records for all patients ages 6 months through 18 years old who underwent surgical lung biopsy for non-malignant pulmonary disease between 2013 and 2023, a period of 10 years. Patients with known or suspected pulmonary malignancy were excluded, as well as those on ECMO. Our primary outcome was diagnostic yield, which we defined as a conclusive result on final surgical pathology. Based on this definition, a conclusively negative biopsy would be considered a positive diagnostic yield because it definitively answered the clinical question. Biopsy reports that were indeterminate or failed to assist clinicians in diagnosing the patient were considered negative in terms of diagnostic yield. We also examined secondary outcomes such as length of stay, time with the chest tube in place, and complications. Our final sample size was 106. Out of the 106 patients, 44 underwent open lung biopsy and 62 underwent thoracoscopic lung biopsy. The median age was significantly lower in the open lung biopsy group, and a greater proportion of these patients had preoperative respiratory support requirement, both of which likely reflect the traditional teaching to perform open lung biopsies in smaller, high-risk patients due to the difficulty of maneuvering long thoracoscopic instruments such as staplers in a proportionally small chest. Just under half our population was white, with no difference in race between groups, and there was no difference in preoperative weight. The past medical history of our two groups was similar, with the most common prior histories being oncologic, followed by inborn errors of immunity, hemosiderosis, and ILD. Our primary outcome was diagnostic yield, which was not significantly different between open and thoracoscopic groups. However, as we expected, the morbidity of open lung biopsy is higher, with an increased length of stay in the open lung biopsy group compared to thoracoscopic. They had similar rates of postoperative chest tube use, and there were 2 patients who underwent additional lung biopsies to clarify biopsy results, 1 from each group. In both cases, the final pathology was also inconclusive. Complications were rare and similar between groups. There was 1 empyema, 1 lymphatic leak, and a similar number of patients who required red blood cell transfusions. We suspect our transfusion numbers are related to the high proportion of oncology patients in our cohort who require regular transfusions to maintain cell counts. The top final pathology results were fungal pneumonia, organizing pneumonia, and interstitial fibrosis. There were no statistically significant differences in the final pathology results between groups. In combination with similar past medical histories, this demonstrates the overall comparable medical condition of our two groups. While the increased length of stay of the open lung biopsy group may be partially attributable to being a sicker population, as suggested by the increased respiratory support, the otherwise comparable disease pathologies at play suggest that the surgical intervention was likely also a significant contributor to the increased length of stay. We're limited by the retrospective approach, which curtails our ability to understand the surgical decision-making that took place leading to our two groups. However, our data shows that diagnostic yield was similar between open and thoracoscopic technique. Additionally, thoracoscopy was associated with a shortened length of stay. When technically safe and feasible, our data suggests that thoracoscopic surgery may be offered to minimize length of stay without compromising diagnostic yield. Thank you. Oops.
All right. This presentation is now open to discussion from the floor.
Raj from Australia. I noticed half of your ventilated patients underwent open biopsy. Is it a reason why you didn't want to do thoracoscopy in ventilated patients?
So they're not ventilated, they just had some support of O2, so they could have just been on nasal cannula. And the idea was that many surgeons would not want to introduce an additional factor needing to clear exogenous O2, for example, which would have worsened their ventilatory requirement if they were on a vent. But because many of them were not on a vent, they didn't want to increase the intrathoracic pressure, which may have then prompted them for going on a vent.
Is it really true?
Sorry?
Is it really true that if you've got preoperative respiratory support, you can't use thoracoscopy? I thought it's the other way around.
We didn't ask that question in our study specifically, but I looked at prior literature in order to sort of look through this data, and that's sort of the general teaching.
Hi, Rami Jamshi from Phoenix. Thanks for your presentation and for asking a very practical and relevant question. I was curious whether you looked into at all the role of image-guided needle biopsies, right? Some centers will do that first. Some people have a bias about whether or not that's useful, particularly when you're chasing an infectious diagnosis. Did you look into that? Do you know how many of these patients had failed an attempt at diagnosis by needle?
That's a really great question, and one that I didn't look into in this study, but would be a great next step, including as well patients that underwent BAL. Almost half of our cohort was in infectious etiology, which may have been potentially diagnosed on BAL. So I don't know that is the current answer, but I think that would be a great thing to look into.
We have time for one more question, quick answer, please.
Yeah, thanks. Great study, important study. This is Marcus Malik from Pittsburgh. Did any of these patients have preoperative localization with coil, needle, dye of any kind? And if so, was there a difference between the two groups?
That's a good question. I didn't specifically analyze that data between the two groups, so I don't know the answer to that. From looking at these patients' clinical charts, very few had preoperative localization. Yeah.
Great. Okay, Dr. Kennedy, thank you very much.
The next presentation will be Contemporary Management of Pectus excavatum, a survey of members of the American Pediatric Surgical Association, to be presented by Dr. Hae-Sung Kang from CHA.
Okay. Hi, my name is Hae-Sung, one of the fellows at Children's National. I'll be presenting Contemporary Management of Pectus excavatum. No disclosures. Our goal in this study was to determine the common clinical and operative practices that pediatric surgeons employ to take care of children with pectus excavatum. We were hopeful that the results may identify opportunities to optimize current PE management strategies. So we employed a 28-question IRB-approved survey. It was offered to the APSA membership via APSA's 2-minute turnover in May and June 2024. Prior to its release, the survey was sanctioned and approved by the APSA Outcome Committee. So as you can see in the map, we had 140 members participate in the survey from 36 states all across the USA. We also had 9 Canadian APSA members who participated and 1 APSA member from Puerto Rico. And 132 respondents here, with 95% of the group saying they currently performed the NUTS procedure. So if you look at this data, 50% of the respondents performed the procedure in a freestanding children's hospital, and the other half performed the procedure in a children's hospital within an adult hospital. The respondents were evenly distributed in terms of years of experience, about 34% over 20 years, 25% 10 to 20 years, and 20% 5 to 10, about 20 for less than 5 years in terms of experience. The workup varied in the respondent choices. However, the common theme was that most people ordered chest CT, PFTs, and echoes. They're the most common, and the least common were 3D printing and psychological assessments. The group's indications for repair varied. The most common was Haller index above 3.25, and social psychological problems related to the defect were the most common indications for repair. And the most common age for repair were 13 to 14-year-olds. Then it was followed by the 15 and 17-year-olds, and very few would repair under 12. Most or 60% of the respondents perform less than 10 NUTS procedures per year. Almost 20% of the respondents perform about 20 to 75 NUTS procedures per year. And about 84% of the respondents actually use cryo for nerve block. And then in addition to that, 38% use intercostal blocks as well. And the majority of the cohort actually is about 60% now utilize a titanium system over the stainless steel. And of course, virtually most or all members use thoracoscopy, which is about 98%, which is a standard of care now. The technical aspects varied amongst the respondents, but most pediatric surgeons use a scope in the right chest or synchronously or intermittently in both chests and pass the bar passer from the right side to the left side. And most of the respondents utilize thoracoscopy and some sort of sternal elevation to reduce the risk of injury to surrounding structures. In terms of the bar size, medium length seemed to be the most popular from anterior axillary line to anterior axillary line. And then the next one would be the long one. And in terms of stabilizing the bar, there was a varied use of unilateral or bilateral stabilizer plates and or sutures or combination of both. In terms of the respondents, 56% recommend returning to full activities after 12 weeks, but over 30%, if you combine them, recommend returning to activities between 4 to 8 weeks. In terms of complications, 75% of the group has had, or a member of their group had, a bar migration that required reoperation or early removal of the implant. And about 17% had experience with hemorrhage during bar placement that required surgical intervention. And about 20% of the group had experience with hemorrhage during implant removal that required surgical intervention. So in conclusion, Haller index and psychosocial concerns are the most common indications for repair. At this point, very few surgeons offer repair to those younger than 12 years of age. And there's a variety of technical approaches to achieve this. It seems that right thoracoscopy and right to left passage of the bar seems the most common approach. Thoracoscopy, sternal elevation, and cryoablation are commonly employed. And it seems that titanium system is more commonly used than stainless steel at this point. And in terms of activity restrictions, there is a wide variety. It seems that some people prefer letting them return to full activities 4 to 8 weeks. Lastly, bleeding complications and bar migration may be more common than the reported incidents based on our survey. Thank you.
We'll take questions now. First, I wanted to say Dr. Kang is from Children's National. There was a typo on my sheet from Child.
Yeah,
So I'm going to hijack the questions. Did you ask, or if not, why didn't you ask about how many people are using 2 bars? Because I'm hearing more and more, especially with a new system that's out, about people who use only 2 bars.
Yeah, we did not ask that question. I think that's a legitimate question. From our experience, we do it based on the appearance of the chest after we place the first one, and then add in another one if needed. And so I think some practices probably use 2 bars regardless, but yeah, that we didn't ask.
I'd also be interested to hear about how you define migration, because I've been seeing a fair bit of my patients rotate a little bit. And whether it's enough to merit reoperation, I think, is a judgment call. But I've been seeing more and more of that with these thinner bars.
Yeah. I think that's per surgeon's question as to what they call migration.
Rami Jamshidi from Phoenix. Just a question to follow up on, along what Dr. Janselis was asking and the comment about bleeding. Was there anywhere built into your survey where you could account for respondents from the same group? If you had 4 surgeons from the same group responding that, oh, we had one patient 10 years ago that had a hemorrhage.
Yeah, I think that's a legitimate question. I think the question as in the survey was very rough estimate, as in that, have you ever had anyone who had a hemorrhage and et cetera? So it's hard to make firm conclusions based on what we asked. And I think it's a legitimate concern with that question, yeah.
Except they can do.
Cortaro from New Hampshire. You are making a comment on it. So your question was kind of leading. Did you ever see a bleeding complication going in or coming out through your whole career? So if you've seen it once and everybody in your group, 10 people in your group say that, you're going to have way overestimation of that. So we really don't know that. So it is maybe more common, but you really can't say that as a conclusion.
I think that's a legitimate point.
Thank you very much.
Thank you.
Next up, we have Dr. Woodward, who can tell us all about thoracoscopic esophageal atresia repairs.
Good evening, everybody. My name is John Woodward from the University of Buffalo and John R. Oshai. I'll be talking about trends and outcomes of thoracoscopic esophageal atresia and tracheoesophageal fistula repair, 2016 to 2022. We have no disclosures. So the first reported cases of minimally invasive surgical repair of esophageal atresia and tracheoesophageal fistula were described in 1999 and 2000. Additionally, we know that complications after thoracoscopic intervention decrease with surgeon experience. Since 2000, there have been multiple papers evaluating MIS versus open repair with mixed results. Some of the reported benefits of a minimally invasive approach have included shorter length of stay, shorter time to full feeds, and avoidance of a thoracotomy and the associated morbidity. Well, some of the reported risks include anastomotic stricture rates and increased rates of reoperation. So our group was interested in further determining the risks and benefits of performing EA and TEF repair thoracoscopically as more and more surgeons attempt and adopt the thoracoscopic approach. Which leads us to our hypothesis for this work, that the rate of thoracoscopic repair of esophageal atresia and tracheoesophageal fistula over time has continued to increase, and with that increase, there are no longer outcome differences between the 2 approaches. So how did we answer this question? We utilized the NSQIP pediatric database from 2016 to 2022, identifying patients less than 30 days of age with both esophageal atresia and tracheoesophageal fistula that underwent repair of both defects. Patients who underwent the MIS repair were compared to the open cohort. We did 2 analyses, one as an intention to treat with the conversion to open in the MIS cohort, and one excluding the conversion to open cohort. We determined the annual rate of MIS repair, and then using the appropriate statistical tests, looked at an outcome analysis, both in a one-to-one propensity score matched data set as well as a coarse and exact matched data set, based off of age, weight, sex, race, prematurity status, cardiac risk factors, and A classification. So we identified over 1,100 patients overall with the intention to treat. We saw 12% MIS utilization in 2016 that increased to 29% in 2022. And when we exclude the conversion to open, it was 8% in 2016, increasing to 20% in 2022. When we look at our outcomes, it is quite equivalent between the two matched data sets. Both demonstrating a longer operative time for the MIS cohort, no difference in postoperative length of stay, no difference in surgical site infections, including at the organ space level, transfusion rates, reoperation rates, mortality, or other outcomes. And when we exclude the converted to open patients, we still maintain the longer operative time for MIS versus open, but now there is a slightly shorter postoperative length of stay. Still with no difference in infections, transfusions, reoperations, or mortality. So using these matching techniques, we compared these cohorts and found increased rates of MIS utilization over the study period with similar postoperative outcomes. And we hypothesized that the increase in thoracoscopic repair of EA and TEF indicates that surgeons are becoming more facile with a thoracoscopic approach, which is driving the decreased short-term adverse events. And when successfully performed, does result in a shorter length of stay. However, we do have limitations with this study. The NSQIP pediatric database is a retrospective database limited to 30 days postoperatively, which does significantly limit our ability to look at things like anastomotic stricture and longer-term complications. So in conclusion, the thoracoscopic approach of esophageal atresia with tracheoesophageal fistula has increased to roughly 30% of repairs. And while it is associated with longer OR times and reduces length of stay, there are no other outcome differences identified, affirming the short-term safety of thoracoscopic repair of EA and TEF. Here are our references. Thank you so much. Happy to take any questions.
Thank you, Dr. Woodward. The presentation is open for discussion.
Yes, Oliver Münster from Munich. Very nice study. Did you look at extubation rates right after the procedure? That's one of the reasons why I think it's beneficial that our anesthesiologists at least tend to pull the tube after the procedure more likely than if it's an open procedure.
So unfortunately, we did not look at that. To my knowledge, the extubation data is collected as of, I think, 2021 and 2022 for NSQIP-P, but I do not think it was in the prior data, so it was not part of our analysis.
And I think you answered my second question already because of the NSQIP. You didn't look at scoliosis rates or anything like that, because that's the reason why I do it, really. Thanks.
Thank you.
So what data do you wish you had that wasn't available in NSQIP that would have helped you answer all the questions in the world that you want to know about?
I think the major thing is the longer-term outcomes. So I think there are many amazing consortiums within pediatric surgery, so potentially gathering more data from more centers on those longer-term outcomes like anastomotic stricture would be really helpful.
Okay, great. Thank you very much. Dr. Woodward.
Thank you.
Our next presentation will be comparing the time of surgery for congenital lung malformations in children throughout the United States, to be presented by Dr. Mota from Florida.
Thank you. Good evening, everybody. Thank you so much for the opportunity for us to present our work. My name is Monique Malta. I'm a general surgery resident at Memorial, and we'll be talking about comparing timing of surgery for congenital lung malformations in children throughout the U.S. We have no conflicts to disclose. Congenital lung malformations are a rare developmental anomaly of the lung that affects 4 out of every 10,000 live births. The abnormal organogenesis or dysregulation of a cellular signaling pathway in the fetal development is thought to contribute to the development of these lesions. And the timing at which this dysregulation occurs is thought to contribute to the type of lesion that develops. And this is a nice diagram that kind of summarizes the lesions that can occur. Oh no. Okay, well. Oh, here we go. Alrighty. So understanding the biology and development of these lesions is important. Management strategy and timing of intervention varies based on patient factors and surgeon preference. We know that patients who are symptomatic will need surgical intervention. However, it's the patients that are asymptomatic that we discover in the prenatal period or incidentally in the postnatal period where the path is less clear and there's some limited guidance. At our institution, our protocol is to conduct a cross-sectional imaging around 3 months of age, and then shortly after this, we normally recommend surgical intervention to avoid the risk of infection and development of malignancies. However, we understand that this differs throughout many institutions and individuals, and that some institutions will operate at an earlier time, and some will have described an observational approach. Our objective was to evaluate national trends and outcomes associated with varying times of surgical resection for these patients. We did this by conducting a retrospective chart review of the nationwide readmission database. This database encompasses about 60% of all admissions throughout the United States and includes about 30 states throughout the US. And we looked at 4 years, from 2016 to 2020, infants less than 1 year of age, and then we subdivided them into 3 groups. We defined early resection as less than 4 months of age, intermediate resection from 4 to 6 months of age, and late resection from 6 to 12 months. And then the outcomes that we looked at included prolonged length of stay, ventilation greater than 96 hours, blood transfusion, 30-day readmission, and 30-day mortality. All in all, we had 615 patients in our population, and they were pretty nicely distributed, evenly distributed throughout all groups. You can see about 1/3 in each group, give or take. These were our baseline characteristics, and you could see that there were some differences between all the groups. Notably, the older groups are more likely to be preterm or have low birth weight, and this potentially is reflecting the age correction in this database. And then also, the younger patients were more likely to undergo an open resection. When we look at our outcomes, our univariable analysis has suggested that there was significant differences between all of the outcomes. However, the multivariable analysis highlighted only 2, and it resulted in the later stage resections were less likely to require longer length of stays and readmission within 30 days. Thankfully, there was no mortality. And the readmission within 30 days was to the same hospital. The outside hospitals did not show the same statistical significance. However, there's very few patients in this section. All in all, the limitations of this study, as any retrospective large database study has, is that we have limited clinical detail, and this doesn't allow us to appropriately identify the risk profile of each patient and look at the perioperative outcomes that could potentially affect the outcomes of our patients. In addition, this database only looks at about 1 year throughout these patients, and therefore the long-term follow-up looking at malignancy and development of their pulmonary function we cannot evaluate. In conclusion, our study suggests that delaying surgery until after 6 months may be associated with shorter hospital stays and lower 30-day readmissions without increased risk of other adverse outcomes. While this study has its limitations, it's a large study population throughout the US, and it truly represents a lack of consensus on timing of surgery, as all groups had about the same amount of patients in each subgroup. This work lays a foundation for future studies and provides further information which could help provide guidance when evaluating patients and counseling parents on management recommendations. Thank you. Right on time.
Open for questions. All right. So I noticed that you didn't mention anybody had preoperative pneumonia or other symptoms besides perinatal symptoms. Did you see any of that? And then why did you cut off at 1 year, if so? Because I had a patient recently who was a year old and got pneumonia, and I was following this tiny lesion because I thought it wouldn't cause a problem. So.
Thank you. We really looked at only the asymptomatic patients, and therefore patients who develop symptoms were not part of this database, or not part of this analysis.
Okay, and then why did you cut off at 1 year then?
So we chose that because usually patients do get resections within 1 year. If the surgery is going to be planned, from what I saw in the literature, usually it's that 1 year. And then there are some patients that go on, like if you approach the observational management way, even those patients, I saw that usually they develop symptoms within like 7 months.
Did you notice a difference in size between the lesions you were observing versus operating on?
Yeah, that's a great question. So something that we didn't look at was the different lesion types. And we know that that really does make a difference also in how we manage patients. So we did not look at the size.
All right, no other questions? All right, thank you very much.
Thank you.
All right, next we have Dr. Lee, who's going to tell us about neonates with congenital lung malformations and how to predict the future with prenatal imaging. Which of those babies are going to need advanced respiratory support or early surgery? Dr. Lee, it's all yours.
Thank you for this opportunity to present our work. We have no disclosures. So congenital lung malformations such as CPAM, bronchopulmonary sequestrations, and hybrid lesions are increasingly diagnosed prenatally due to advances in fetal ultrasound and MRI. While most are asymptomatic, a subset of neonates decompensate at birth and require urgent intervention. The challenge lies in predicting which fetuses will fall into that high-risk category. Current imaging can detect lesions earlier and more accurately, but clinical outcomes remain difficult to anticipate. If we could better stratify risk based on prenatal imaging, we could optimize counseling, delivery planning, and early management. That's the central aim of our study. This study was designed to evaluate whether specific prenatal imaging features are associated with the need for early surgical intervention or advanced respiratory support in neonates with CLMs. We propose that such imaging characteristics assessed during fetal surveillance could serve as objective predictors of postnatal clinical severity. Establishing this association may provide a framework for more individualized perinatal management in affected pregnancies. Here are our methods. This was a retrospective study using data collected from over 20 years, 2002 to 2023 at a single tertiary care institution, Riley Hospital for Children. Of the 113 fetuses with a prenatal diagnosis of congenital lung malformation, we included 106 term neonates who had complete postnatal data and fetal MRI imaging. We excluded preterm neonates to minimize the confounding impact of pulmonary immaturity on respiratory outcomes. Our composite primary outcome was defined as either early thoracic surgery within the first 30 days of life or the need for advanced respiratory support, including high flow oxygen, BiPAP, CPAP, or mechanical ventilation within the first 24 hours after birth. Prenatal imaging consisted of detailed ultrasound evaluation, including calculation of the congenital pulmonary airway volume ratio, or CVR. This metric incorporates lesion size in relation to fetal head circumference. All patients in the study underwent an initial fetal MRI between 24 and 30 weeks gestation. MRI metrics were included lung lesion and total lung volumes, segmented using a semi-automated approach. We performed both univariable and multivariable logistic regression to identify imaging features associated with early intervention. Predictive model performance was assessed using receiver operating characteristic curves, and complementary metrics included the KS statistic and the Gini index. Here are our results. This table shows perioperative data for the 18 neonates who required early intervention. In the early surgery group, the median age at surgery was 0 days. Most patients had CPAM. The most common complication was persistent air leak, occurring in 44% of these patients. In the advanced respiratory support group, 5 patients ultimately underwent delayed surgery at a median age of 5 months, while 4 did not require surgery. These findings highlight the variability in timing and type of intervention, even amongst high-risk patients. The remaining 88 neonates formed the control group, with 49 of them ultimately undergoing delayed surgical resection during the study period. In the univariate analysis, the early intervention group demonstrated significant larger lesion volumes on both prenatal ultrasound and MRI. They also had a greater percentage of lesion growth during prenatal evaluation compared to the control group. However, CVR and observed over expected total fetal lung volume did not significantly differ between groups. The image shown in this slide is a prenatal MRI from a patient in our cohort who required early surgical intervention. This table shows the results of our multivariable logistic regression analysis. When adjusting for multiple imaging variables simultaneously, ultrasound lesion volume emerged as the only independent predictor of early intervention. It had a statistically significant odds ratio of 1.077, which means that for each unit increase in ultrasound lesion volume, the odds of requiring early intervention increased by 7.7%. The confidence interval did not cross 1, reinforcing the significance of this finding. And finally, the ROC curve compares ultrasound and MRI lesion volumes for predicting early intervention. Ultrasound had a higher area under the curve compared to MRI and a higher Gini index, indicating better overall model performance. However, MRI had a higher KS statistic, suggesting it was better at distinguishing extreme cases. Overall, ultrasound provides better general discrimination, while MRI complements by identifying the most severe cases, supporting the use of both modalities together in prenatal decision-making. So in conclusion, prenatal imaging plays a critical role in identifying CLM patients who may require early postnatal interventions. Ultrasound lesion size was the strongest independent predictor of early intervention, supporting its role in routine prenatal risk stratification. MRI adds complementary value, particularly in distinguishing high-risk extreme cases. These findings highlight the need for standardized prenatal imaging guidelines across institutions, and our study limitations include retrospective design, a single-center population, underscoring the need for multi-center prospective studies. I would like to thank Dr. Gray and our multidisciplinary team for supporting this project. I'm happy to take any questions.
Raj from Australia. I have similar numbers. I have two questions. The first one is the timing of MRI. Normally, we detect these lesions at 20 weeks, and then MRI is done between 20 to 26 weeks, usually around 24 weeks, whereas ultrasound is repeated every 3 months. So you may be using the ultrasound, which is the most recent ultrasound, to predict the outcome. I don't know, so I have to know which ultrasound you use to predict. And number two, there are a lot of studies which says bronchial atresia does not need a surgical intervention. But you have shown bronchial atresia with distress requiring surgery in about 4 of your kids already. So I'm just a bit confused.
Yes. So for the ultrasound that we used for the study, we used an ultrasound in the later second trimester that was the highest lesion volume on ultrasound. And now, just as you said, MRI is done considerably less frequently than ultrasound, and it's easy to find a higher number of ultrasound because we do so much more of them. I think one thing that's interesting about this study is it shows how MRI can be a complement to ultrasound, and show us in certain severe cases, maybe we should do a couple more MRIs in those patients. And we have more data with multiple MRI for patients. We can draw more conclusions about how it relates in those high-risk patients. And then the second question was about bronchial atresia. So we did include bronchial atresia as part of our screening for this. I've seen multiple studies, some include it, some don't include it. But the 4 bronchial atresia patients, I've read all the charts for those 4 patients. They had a surgical procedure, and since then we're seeing in clinic with positive outcomes. So I think especially if they are born early, they have prenatal findings and then are born with respiratory distress, those might be the patients specifically with bronchial atresia that would best benefit from surgery.
Can I ask people?
Less than a minute for the question and response, please.
Yeah. Can I ask this?
Please.
You guys, as well as everybody, would you operate bronchial atresia? That's a question I want to know.
Well, bronchial atresia, as you know, is the underlying mechanism to all these congenital lung malformations. They're just macroscopic or microscopic. It's a tough question. It varies geographically. It varies with practice. It varies with symptoms or not.
Yeah, I've seen some
short,
patients,
easy answer.
Yeah, I've seen some patients outgrow it if they have problems early on. As the bronchus gets bigger, but in general, I don't operate on it personally.
Thank you.
All right, our next presentation is Impact of Prematurity and Gestational Age at Surgery on Diaphragmatic Plication Outcome, is to be presented by Ava Herzog from Albany, Saratoga Springs, Albany Medical College.
Okay, hi everyone, my name is Ava Herzog, and today I will be presenting our project titled The Impact of Prematurity and Gestational Age at Surgery on Diaphragmatic Plication Outcomes.
Advance first slide, please. There you go.
So diaphragmatic eventration, or DE, refers to an abnormal elevation of the diaphragm, usually due to incomplete muscle development or poor innervation. Surgical plication, which involves the folding and suturing of the diaphragm in order to reduce its size and improve lung expansion, is the most common treatment for symptomatic DE. However, there is still some controversy about the optimal timing of surgery, especially in terms of how prematurity and gestational age at surgery, or GAS, affect outcomes. Our study aims to fill this gap by analyzing a large pediatric cohort.
Advance slide, please.
Okay, so to answer this question, we queried the ACS NISQIP database from 2016 to 2022 for all patients who underwent diaphragmatic plication. We compared outcomes such as mortality, ventilation, oxygen requirement at discharge, reoperations, readmissions, and major complications. We utilized chi-square tests and multivariate regression to analyze the effect of prematurity and gestational age at surgery, or GAS, on outcomes. We divided GAS into 5 clinically meaningful timeframes. We had newborns as less than 44 weeks, early infants as 44 to 60 weeks, late infants as 60 to 90 weeks, toddlers from 90 to 200 weeks, and older infants as greater than 200 weeks. We included 252 patients in our analysis, with most surgeries being performed in newborns and early infants. 18% of the patients were premature, and 53% had surgery at less than 60 weeks corrected age. Premature infants were significantly more likely to undergo early surgery compared to full-term infants, and patient demographics were otherwise largely similar among the dataset. Our cohort overall had high clinical complexity, with 78% of the patients having an ASA class of 3 or greater. Early GAS patients had significantly higher ASA classes, with near significant trends when sorted by prematurity. Rates of prior cardiac surgery, which is a major risk factor for acquired DE, interestingly did not differ by GAS or by prematurity. For regression analysis, we utilized 90 to 200 weeks as the reference point for GAS, as shown in red, and after adjusting for ASA class and prematurity, major complication rates were 1.6 times more likely in premature patients and 2.2 times more likely in those with a GAS of less than 44 weeks, indicating that GAS is a stronger predictor than prematurity alone. Complications were least prevalent between 60 and 90 weeks. As you can see on the right, when adjusting for ASA class, prematurity, and operative approach, early GAS predicted longer hospital stays. Of note, both GAS and prematurity also predicted post-op ventilation rates. Our study is the largest pediatric cohort, specifically examining how prematurity and surgical timing affect diaphragmatic plication outcomes. Prior studies have shown that prematurity increases post-op respiratory risk, and that early surgery in neonates is associated with higher mortality. Our findings, while consistent with these trends, importantly highlight that GAS, as opposed to prematurity, is the more powerful predictor of poor clinical outcomes. This suggests to us that congenital and acquired DEs may behave differently after surgery. Of course, it's important to recognize some limitations. So while we can suppose that premature infants are likely not acquiring DE, but rather have congenital DE, the NISQIP database cannot officially differentiate between the two. Birth trauma data was also missing in this database, important because congenital DE is more common in preterms. Outcomes were also limited to 30 days postoperatively, and gestational ages at surgery were broadly categorized, which required us to provide some estimated corrected ages. Incomplete data of surgical techniques, intraoperative variables, imaging, and social determinants of health are an inherent limitation of the NSQIP database, as well as potentially inflated complication rates. Despite these limitations, our findings provide important clinical insights as the largest pediatric cohort specifically examining the effects of prematurity and surgical timing on plication outcomes. Prematurity and early GAS are strong independent predictors, with GAS being the stronger predictor of poor clinical outcomes, emphasizing that the timing and possibly the underlying nature of DE, so whether it is congenital or acquired, may play major roles in outcomes. These findings can help surgeons better counsel families and guide timing decisions. Future research should investigate long-term outcomes and better distinguish between congenital and acquired types of DE. Thank you very much for your attention, and I'm happy to take any questions.
A great presentation. So you said that the database doesn't let you know the difference between congenital versus iatrogenic plication indications. So how did you know that the proportion that were premature or not?
So that's something that we did have to kind of infer. We kind of assumed that premature patients were likely having congenital DE as opposed to acquired DE, just because they're less likely to have the shoulder dystocia during any sort of birth trauma. But that was a big limitation of our study.
Okay, yeah, definitely indication would be very important to distinguish between those two groups, right? Okay. All right, it's a tough population. Thank you very much.
All right, next up, we have Professor Munster to tell us all about stents and benign esophageal disease.
Yes, thank you so much for having us here. Unfortunately, Johannes, who was going to give the talk, the medical student that was doing this with me, didn't make it, so I have to give it for him. Yeah, so there's no conflicts of interest. I own stock options in Mica Labs, which make the magnets, the Connect-EA magnets for esophageal atresia repair. Has really nothing to do with stents. So stents have been around for decades to treat stenoses and other issues with esophageal atresia, but there are only very few series that actually investigate their application. Biodegradable stents have been around much less time and are less investigated. So we think this is important because we characterize biodegradable stents as an additional option for selected cases of esophageal atresia and benign esophageal problems. So the detailed aims of this study were to compare efficacy and complication rate of biodegradable stents, as you see up there on the right, with self-expanding fully covered metal stents, which have been around for a longer period of time, in the pediatric patients with esophageal problems like strictures, leaks, and perforations. So this was a retrospective study over 8 years that comprised all patients that underwent stent placement at our institutions, the LMU University of Munich, where I work right now, and my previous institution, the University of Mainz. The primary outcome that we chose was time to reintervention and treatment success, meaning that there was no further intervention necessary upon last follow-up. And the secondary outcome were stent complications. So we used either these self-expanding metal stents or the biodegradable stents. These are all not licensed for children, and so they're all off-label use, and they're quite expensive. And the biodegradable stents are actually about twice as expensive as the other ones, the more conventional ones. So our study comprised 20 patients, 4 males and 16 females, at a median age of 1.6 years. Most of them had esophageal atresia, but there was one case of severe caustic injury. And as you can see, they all had a number of other interventions, including Fokker and Kimura techniques and combinations thereof, some interpositions. So these were definitely the more complex and more difficult kids with esophageal atresia. We placed a total of 79 stents in these 20 patients, so that makes for a median 2.5 stents per patient. The number of biodegradable stents were 33, and we placed 46 self-expanding medical stents. And the procedure time was in general a median of 42 minutes, but some of these comprised other procedures as well. And the time interval between one and the next stent placement was in a median 91 days, so about 3 months. We placed them for stenosis, fistula, leaks, and combinations of thereof. This is a Kaplan-Meier curve of the stent failure, so whenever something had to be done with the stent that was placed. And as you can see, actually some minority, but some patients actually did achieve a resolution of their problem. And the BDS-treated patients, so the biodegradable stents, they were associated with a 52% lower relapse risk compared to the other more conventional stents. The time to intervention was also larger in the biodegradable stents, and this was significant. So if you looked at the complications, stent placement is a procedure fraught with complications. 50%, or about half of our stents, had some kind of complication. The most common type for the self-expanding metal stents were dislocations, as you see here. And the most common complication for the biodegradable stent were actually granulation tissue forming inside the esophagus where the stent was placed, as you see here in the endoscopic image. We had 4 treatment successes where nothing else was necessary, only the stent placement. There were 11 cases where further endoscopic treatment was necessary, so mostly dilatation, and then there were 5 patients that actually underwent surgery afterwards. And this was at a median follow-up of 5 months, ranging 3 to 34 months. So the take-home messages are that early stenting, although a lot of complications can arise, and complex EA cases may prolong intervention-free intervals. And although the relapse may occur, it actually keeps the kids out of the hospital for longer periods of time if you take the biodegradable stents. The most common complications were stent migration and granulation tissue forming. And you have to be careful because these devices are not licensed for kids, so it's all off-label use and they have a high cost. But we believe that one possibility, and we're working on that, is 3D printing of custom-made resorbable stents, which may provide us a future solution. Thank you. This is my team.
A pretty good presentation for a rookie. Talk's open for discussion.
Oliver, great talk. Ben Sendejas from Boston. Nowadays, how do you choose between the self-expanding metal versus the biologic? Like, what factors in your decision?
Yeah, that's a good question. So, of course, that's multimodality. You know, so I have a lot of kids that come from places other than our center, so other countries. And I like using the biodegradable stents because they don't dislocate. That would be an emergency where they have to come back quickly. And also it keeps them out of the hospital. So these are often the kids that, as you know, I mean, they need dilatations every week or every 2 weeks. And you can give, these stents generally stay in place for 2 months and then they dissolve. So you give them, a relatively long time to not be in the hospital. So that's one of the factors. The other thing is that if I believe it's something that just needs a little bit of dilation, I'd put in a self-expanding metal stent and take that out after a week or 2.
Hey, Paul Waltz from Pittsburgh. Thanks for detailing that experience. How did the granulation tissue present? Did it require any treatment, or was it just found at the time of exchanging stents?
Yeah, it's generally found when you go back in. And that's a good question because usually it's not symptomatic till you have to go back in and then you see it. And I do think that the granulation tissue sort of, it's something you kind of make the pact with the devil. There's more granulation tissue and that leads to more problems in the end, or restenosis. So I don't know, but but definitely we found it in the re-intervention for the next whatever intervention, dilation or stent placement. Mike.
I'll apologize. We have just time for one more question. to speak with Dr. Munster after his presentation.
Hi, Oliver. Good to see you. Very innovative, which is not surprising. Very nice presentation. Did the babies tolerate the stent well? They didn't cough or gag or?
So it's a good question because there was a time where we use these adult stents, right? And the self-expanding, the biodegradable stent only came in 8 centimeter lengths, which is huge. And nowadays you can get custom-made stents. But I do think that printing them at some point will be the solution for that. And the huge stents, I mean, they're not tolerated very well if it's in a very small baby.
And you haven't done this in the older kids, the stent?
Oh yeah. In the older kids, it's no problem.
The ones we try, they seem to just be suffering.
Really?
Yeah, just gagging and just very uncomfortable.
The resorbable ones?
No, the self-expanding ones.
Oh, the self-expanding, they come in all kinds of sizes.
They do.
They're not a problem.
We'll talk offline.
Okay,
I
well.
think they're staring at me.
Okay. I'll try to.
It's okay, Dr. Munster, you can stay there because now we're going to talk about telemedical interdisciplinary care for patients with esophageal atresia.
Yes, thank you so much. Do you want to start it? Good. Yeah, so thanks so much for the opportunity to present this work. We again have no conflicts of interest. This work was funded by a grant by the Innovation Grant of the GBA. And the GBA is kind of the steering committee for healthcare in Germany. So they're looking for innovative ideas, how we can shape healthcare in the future. So why did we do this? Esophageal atresia care in Germany is decentralized, as it is in the States. So everybody can do it. A lot of people, a lot of centers do it. And in fact, most centers only take care of 0 to 2 babies over a course of a year. And we think that because the expertise is diluted, this may impact outcome negatively. In fact, there is data that mortality rates for esophageal atresia are in the lowest double digits, much higher than in countries surrounding Germany where care is centralized. So we thought that maybe telemedicine can bridge this gap between centralized competency and sort of local availability of care, which is the argument for decentralized care. So we've all done this before, really. We talk to each other. We call each other up. Hey, I have a case. It's really difficult. Can you help me with that? Have you seen this before? You have published something on this. We've done it, but we've done it in a very unstandardized way. And the questions are, does the person get paid to give their expert opinion? What about data privacy? We do this via WhatsApp and Telegram and that kind of thing. And really nobody learns from it except for the person on the receiving end. So we tried to build a system that would address all these issues. And it's called TICP, Telemedical Interdisciplinary Care for Patients with Esophageal Atresia. So here we have a network of experts in high-volume centers that are available for surgeons or pediatric surgeons and practitioners elsewhere. And so the study that we did was we enrolled participants, anybody in Germany who was taking care of a kid that had esophageal atresia in the first year of life could enroll them, and they would have access to this multidisciplinary team of telementors. The study went from 2020 to 2024 for reason of COVID. It was extended. And then we looked at the outcome and compared it to controls, A, from the patient support group registry, and secondly, from the insurance companies. And our primary outcome parameters were A, mortality, of course, and secondly, the number of dilatations in the first year of life, just because it's a very easy number to catch. So this is how we did it. We used a platform that is, the equivalent of HIPAA approved in Germany. It's called Big Blue Button. Don't ask me, but that's what it's called. And so we were able to enroll over those 4 years, 100 patients with EA. 6 were lost to follow-up, so we had 94 that remained for analysis. We did 312 consultations in this network with 3.3 consultations per patient, and each consultation lasted a median length of 10 minutes. So it was not onerous, either for the expert or for the participant. The participants tended to include their kids at a median of 51 days of life, and unfortunately we only had about 20% enrollment before the first operation, which was really a goal that we wanted to achieve. So there were 59 surgeons and healthcare practitioners that sent us their patients at 19 university hospitals and 9 non-university hospitals, and they were paired with 59, not necessarily 59, this is just by chance, but 59 experts, the pool of 59 experts consisting of 48 pediatric surgeons, 10 pediatricians like pediatric GI and pulmonology, and 1 pediatric anesthesiologist for anesthesiology questions, mostly university hospitals. So in our group, in the TICP group, there were 1.8 dilatations per patient, which was really a low number, as we'll see later on, for the types of patients entered. And the mortality was 3.2%, markedly lower than in what was published. So these are our outcomes. So the TICP patients were much more premature, they were lighter, they had more type A and complex esophageal atresia, they had more cardiac malformations and VACTERL, and they still, despite of this, despite being the more complex group, still had only 1.8 dilatations in the first year of life. Very comparable to the others, but they were not the sicker ones. So the participants in this TICP trial that entered their patients when they were more sick, when they were sicker and more complex. That's not surprisable. That's the ones that you need help with. Despite being this select group, they had a similar dilatation rate. They had a markedly lower mortality rate, and most patients were included into the study after the first year of operation, which is something that we need to work on in the future. But we think that this is a good concept that may be applicable in these types of healthcare settings for other rare diseases that we treat like Hirschsprung or anorectal malformation. And this is our TICP study group. We actually won the prize for telemedicine intervention in Germany last year, and I'm glad to take any questions. Ben.
Again, great talk. I noticed that a lot of the complications lead to this sort of failure to rescue, and that snowballs into more complications and the really challenging outcomes that we see sometimes. So did your study pick up on any of those events where you noticed that you were able to help them navigate those complications and either help them get through it without additional complications or transfer to higher level of care? And would that have been a good outcome to follow?
So that was one of the big criticisms from the patient support group. You make decentralized care possible with you're supporting decentralized care. We all want centralized care. So one of the things was that we trained the experts. They were all sort of trained to give Ernica and ESPGHAN guideline recommendations. And there were 5 instances where the expert said, listen, this is not a kid that should be at your center. Right. We need to transfer them. And they did. And I think it is helpful because the participant could really say, listen, to their hospital administration, I talked to an expert. They think we need to transfer. We have to do it. And I think it's helpful. But of course, it's the best thing would be we would all be taking care of these kids in 10 really good centers. But that's not the reality in my environment.
This is Raj from Australia. We do the similar thing where the distance is long and therefore it's a problem. My question to you is, in difficult cases like long gap esophageal atresia, do you go and help the local surgeon so that next time he doesn't have to talk to you?
Yeah, I don't do that. I want them to transfer to our place. I will invite them to come and we'll operate on them together. I personally don't like operating in an environment where I don't know, the infrastructure. and the people I work with in these very difficult kids. So I'm more for sending them central to a high volume center.
Which aspect of the telemedicine setup is helping them avoid dilations? Because, in our center, speech therapy is extremely important. It's hard to do that over telemedicine.
Yeah, that's a good question. I'm just happy that it turned out that way. But I was wondering about that. Maybe it is because you detect leaks or something earlier. Maybe it is because, you just... Some people even dilate or do things when they shouldn't. And sometimes when I was doing the expert opinion, I told them, listen, your kid's doing fine. Just don't even go in there. Don't look. And we'll see you online in 2 weeks again. And then, you can pick them up from there. Maybe we avoided dilatations by that. I don't know.
Thank you very much.
And next we have Dr. Chandler. Tell us about her presentation, Assessing Cardiac Compression in Pectus Excavatum, Role of External Caliper Measurements. Dr. Chandler, it's all yours.
Thank you. Is this the advance? All right, perfect. Thank you very much to the program committee for allowing us the privilege of presenting our work today. I'm going to be talking about the assessment of the role of external caliper measurements in assessing cardiac compression in patients with pectus excavatum. We did this research to define the role of simple external caliper measurements in assessing cardiac compression in patients with pectus excavatum. This is important because the modified percent depth, if associated with cardiac compression, can further validate the usefulness of using these caliper measurements in assessing the severity of pectus excavatum. Sternal depression due to pectus excavatum can cause cardiac compression, most often of the right ventricle. And there are previous studies that established cardiac compression classification based on MRI, and this was correlated between the imaging on the MRI associated with the right ventricular heart compression. In 2020, it was published that the modified percent depth has a sensitivity and specificity that are very similar to the pectus index and the correction index. These measurements are performed with the Martin breath chest calipers, and there are 3 measurements that are recorded from the mid-posterior spine to the deepest depression of the sternum, as well as to the mid-anterior chest at the site of the largest protrusion. The hypothesis of this study was that there is an association between the modified percent depth derived from external caliper measurements and findings of cardiac compression by imaging in patients with severe pectus excavatum. This was a secondary analysis of a prospective multi-center observational study, including 8 centers that participated in a regional research consortium. Patients were included in the study if they had uncorrected pectus excavatum between the ages of 6 and 25 years, if they underwent preoperative imaging, including echocardiogram, CT, or MRI, and if they had preoperative external caliper measurements performed. Demographics, symptoms, pectus index, and external caliper measurements were recorded. All imaging reports were reviewed to determine the presence or absence of cardiac compression. Patients with and without cardiac compression were compared using standard statistical tests. And we assessed modified percent depth hold thresholds at different values and assessed its ability to predict cardiac compression. These values were set at 14 and 25%, and these values are based on prior studies as well as the current study population distribution. Logistical regression was then used to adjust for potential confounders. 143 patients were included in this study, and there were no differences found in demographics or presence of symptoms between those with and without cardiac compression on imaging. When looking at the severity of pectus excavatum, patients with cardiac compression had a higher pectus index of 4.2 compared to patients without cardiac compression who had a pectus index of 3.8. The modified percent depth was significantly higher in patients with cardiac compression at 25% compared to those without cardiac compression at 21.3%. When adjusted for age and gender identity, patients with a modified percent depth of greater than or equal to 25% were more than twice as likely to have cardiac compression. Limitations of this study included that imaging was not independently reviewed. Reports may or not have included cardiac compression when it was present, thus overall underestimating the true incidence of cardiac compression in these patients. We also noted that there was no standardized imaging reports indicating the presence or absence of cardiac compression for patients with pectus excavatum. This also included tests that were both dynamic and static in their technique, and the differences between identifying cardiac compression on these modalities is unknown. In summary, the study found that a higher modified percent depth was associated with cardiac compression, and that in patients with a modified percent depth greater than or equal to 25% were significantly more likely to have cardiac compression. And after adjusting for age and gender identity, modified percent depth of greater than or equal to 25% remains statistically associated with cardiac compression. In conclusion, this was the first study to show external caliper measurements are associated with the presence of cardiac compression. Pectus excavatum patients with a modified percent depth of greater than or equal to 25% have a much higher likelihood of cardiac compression. We also identified the potential opportunity to standardize imaging reports to document the presence or absence of cardiac compression in patients with pectus excavatum. I'd like to thank the Eastern Pediatric Surgery Network for allowing us to perform this study, as well as the institutions that contributed to patients to this study. Thank you, and I'd like to take any questions if we have time.
And this presentation is open for discussion. Who wants at it?
Dan Cortaro from New Hampshire. Thank you for this very nice study. It's a very elegant way of looking at the potential for cardiac compression. One of the things that always is interesting in looking at patients with pectus excavatum is that the depth of the deformity is often looks greater when the patient is in the standing position than in the supine position. So use of the calipers may be much more accurate in identifying cardiac compression than any of the imaging studies that we do, because they're always done with the patient supine when they look better. You notice that when you take your patient to the operating room as well. They don't look so bad when they're laying on the table, but when you stand them up, they're much different. So thank you for this great presentation.
Thank you, that's a great point.
So I'd love to hear your thoughts, now that you've sort of really delved into this, do you notice any differences between true compression versus displacement?
Yeah, I think that's really the question, right? I think it's very interesting that the patients with cardiac compression on the imaging didn't really have any difference in symptoms that were reported compared to the ones that didn't have compression. So really kind of tease that out. Is it really the patients with significant symptoms that are important? But we know that patients without cardiac compression on imaging also report those symptoms. And so where's the gist in there? So.
And as you pointed out earlier, how can you tell from just the static images? Mm-hmm. To really show cardiac compression, would echo be a dynamic imaging modality, be better to define one from the other?
Yeah, it's actually interesting. I have a slide, I won't bring it up, but actually more of the cardiac compression was identified on CT and MRI than it was on echo on the study. So is it that just that the people performing the echo are not tuned in to look for that or to report it on the echo the way that the radiologists are on the CT or MRI?
Okay, Dr. Chandler, thanks for the talk.
Thank you.
Our final presentation is tracheobronchopexy and bronchopulmonary dysplasia, infants with severe tracheobronchomalacia, to be presented by Dr. Shea from All Children's / Boston.
Okay, thank you for the opportunity to present today. We have no disclosures. Preterm infants with severe bronchopulmonary dysplasia have parenchymal lung injury and associated pulmonary hypertension. They can suffer from prolonged intubation, dependence on positive pressure ventilation, and tracheostomy placement. A subset of these patients can also present with severe tracheobronchomalacia, characterized by excessive dynamic airway collapse, leading to desaturation spells or high airway pressure requirements. Our group has previously shown that surgical tracheobronchopexy is effective in improving respiratory outcomes in children with tracheobronchomalacia, both primary disease and secondary to esophageal atresia. However, little is known about its efficacy in those with BPD. We describe our experience with tracheobronchopexy in severe BPD TBM infants. These techniques include posterior tracheopexy, which fixes the posterior tracheal membrane to the anterior longitudinal ligament of the spine, or anterior tracheopexy, which fixes the anterior wall of the trachea to the sternum with bovine pericardial struts, and these are all done under direct bronchoscopic guidance. We reviewed BPD patients who underwent tracheobronchopexy for desaturation spells, failure to wean positive pressure ventilation or extubate, or pre-existing tracheostomy with high ventilator settings from April 2019 to August 2024 at a single institution. Patient characteristics, surgical techniques, and respiratory outcomes were reviewed. 19 BPD infants with a median gestational age of 25 weeks underwent 21 tracheobronchopexies at a median corrected gestational age of 5 months for mostly desaturation spells, followed by PPV, ventilator dependence, and pre-existing tracheostomy with high ventilator settings. On preoperative bronchoscopy, all demonstrated complete dynamic airway collapse of the large airways. Surgical approach was mostly posterior with combined tracheopexy and bronchopexy. Concomitant procedures included cervical tracheopexy, posterior descending aortopexy, and resorbable external airway splits. Comorbidities included gastroesophageal reflux disease in 81%, with 29% requiring fundoplication and 38% requiring gastrojejunostomy, and pulmonary hypertension on medication in 1/3 of infants. At latest follow-up of median 12.5 months, there were no recurrent desaturation spells, a significant decrease in ventilator dependence, and overall significant improvements in respiratory status from baseline. Only one infant required new tracheostomy. Of those with pre-existing tracheostomies, there was significant mean PEEP reduction of 6.25, and there were no significant surgical complications or mortalities in this group. So in conclusion, in severe BPD TBM infants, tracheobronchopexy significantly reduces desaturation spells, ventilator dependence, and PEEP requirement. This surgical strategy is safe and effective in select infants for improving respiratory status. We consider spells being a significant component of disease and ventilator settings that are prohibitive of discharge. Those with less severe parenchymal lung injury and pulmonary hypertension, both of these make surgical intervention less risky. And some may also have small airway malacia that may still benefit as long as the large airway malacia component is significant. Thank you. I'll take any questions.
Well, thanks very much. So I'm interested in, I know this isn't a technique talk, but I'm interested in how the procedure has evolved over time, and if you've accounted for any changes in technique and seen any differences with those changes over the course of the study.
Over the course of the study?
Of how long you've been, over the course of how long you've been doing the procedure.
I think our technique for the tracheopexies has remained relatively consistent throughout. Obviously, the experience has increased over that time period. I think the BPD infants weren't like the first group that we were doing tracheopexies on. It's sort of been later on, just with difficult kids in the NICU, that we've sort of been exploring the use of this in this population.
Right. I guess what I'm asking is, have you noticed that the response is better, or that your technique has improved over time, or that experience is really a big factor in that, or whether I can go in and learn this technique and have good results right from starting to do it? Because it's a challenging procedure.
I think experience is a factor. I think that's an ongoing kind of talk where there are certain centers that are very experienced, and then places where certain physicians are coming out to learn from us.
Mm-hmm.
So.
Yeah.
So thank you so much. I mean, it's a very interesting technique. I'm not totally sold on it yet, but maybe you can. So you said there were 8 that were on trachs, and you made it sound like it's a great achievement that only one of the rest got a trach. But really what I'm interested, you do this intervention so that you wean off the trach easier, right? I mean, faster, you want to get them off that. How many came off the trach, or did it help wean them off the trach?
Yeah, so I think there are different indications for this. There's the group of kids that we are doing a tracheopexy to avoid a tracheostomy, so to get off positive pressure, avoid spells, or try to extubate and avoid a tracheostomy. And then there's the group that already has a tracheostomy and they're on very high ventilator settings that they're unable to go home on, or they're having spells. So you're doing a tracheopexy in those kids to either bring down the ventilator settings or reduce the spells so that they're able to go home.
And you said the PEEP was lower, but
Correct.
you didn't give any, like you didn't give us numbers.
The mean was a 6, so I think the range from the top was like 10 to 18, and then down to like 6 to 10. But the mean is around 6.
What you really need is a control group in order to see what is the effect of the tracheopexy. That's what my suggestion would be. Then I really buy it.
Yeah, I think, well, it's difficult to have a control group because these are the sort of the kids that the NICU, they're obviously a difficult patient population that the NICU doesn't really know what to do with. So we're either trying to avoid a trach or we're trying to figure out a discharge plan.
Right, but
so
I mean, it's a new intervention, relatively new, let's say, and you could say, well, I mean, yeah, I understand maybe you don't have equipoise and you think all of these kids need it, but most of us would say, like, most of these kids don't get it in the United States. Let's randomize them and give them, some of them get it and some don't, and then we'll see if the ones that get it are better off,
Yeah, I mean, there's a little bit of bias because for a lot of our patients, there are sort of referrals coming to us that, they're asking for a second opinion. And so I think if anatomically there is severe tracheomalacia and, on the CAT scan that we can do an operation, then in our hands, we would be doing an operation to deal with that.
We still have some time, so go ahead.
Hi, Stephanie Please from Mayo Clinic. Thank you for this talk and for sharing your experience. It's great. 2 questions. One, wondering if you can comment on how you time this. I guess it's a little bit getting at what he was talking about, but how do you time this, waiting long enough that they really need it, but not so long that they've had all this additional potentially preventable lung injury? And then my other question is if you ever encounter the sequelae of air trapping intraoperatively, like once the chest is open, if that makes it more technically difficult than lungs that don't have terrible BPD and are gonna kind of collapse a little more.
Those are good questions.
Thank you.
So first one, the timing of it. So this is sort of like an ongoing discussion with the NICU. A lot of times we're talking to the NICU about trying to wean the ventilator settings, and if they feel like they've reached a point where they can't wean, then we'll do a bronchoscopy and see what the airway anatomically looks like. And then you'll have to see whether, how big the kid is, whether with the associated comorbidities, whether they'll be able to tolerate an operation. Sometimes we'll then, if they're on the smaller side, we'll then wait until they grow a little bit bigger and sort of see what the trend of the symptoms are. So I think like a difficult decision, but I think discussion with the NICU and also with anesthesia team. And then in terms of the air trapping, I think in general, the kids with BPD, we just have to do like very minimal lung retraction when we're doing the operation, and still be able to get the same effect.
Really great presentation. Jamie Robinson from Vanderbilt. I was curious about your experience with the anterior tracheopexy cohort, and if you have patients with BPD who have had success with an anterior aortopexy and a nominopexy. For example, if there are some individuals who may not tolerate a posterior approach very well. Unlike Oliver, I do buy into the posterior tracheopexy cohort group, but I am interested in the anterior approach as well. Great job.
Yeah, that's a good question. I think most of the kids in this cohort did get posterior tracheopexies. I think a couple got probably both posterior first and then anterior. I think it all sort of depends on the bronch and what the CAT scan looks like, but that is an option.
Okay, Vogel, you got 30 seconds.
Anna Vogel, Houston. I just wanted to add just a comment to what was going on with Oliver earlier. These are incredibly complex, very sick kids, and the impact that this technique can have and this procedure can have on them it can really be quite profound. I mean, you've illustrated in your data, when you think about those clamp down episodes, those life-threatening episodes that go on with their desaturations, when you think about the discharge planning for these kids, these medically complex NICU kids, when we know that the natural history of this disease is that it will get better. These kids will get better as they grow. They just need to stay alive to get there. The ability that we have with this technique, with the data that you've said, to give them that chance, the safety aspect, going home on a PEEP of 15 versus a PEEP of 7 or 8 is huge and can really be meaningful, not only to these children, but the complex medical teams that provide for them. So I really thank you for bringing this experience and presenting it to the group.
Thank you.
All right, thank you very much. Thanks to all of our presenters. Please stop by our vendors and check out their offerings. And you have some free time in the welcome receptions from 7 to 9 at Agora, which is in the lobby. So enjoy. Thanks.